Good afternoon, everyone. So I welcome you all to the interesting nail cases panel discussion now. And we are very happy to have with us two international nail experts, Dr. Faisal Al-Sibai from Kuwait and Dr. Michela Starace, who is also a nail expert in addition to being a hair expert from Italy. So we shall be discussing 4 interesting nail cases that you may have in your clinic, and they will help us to decide on the patient's treatment. So my first case is a 32-year-old male who presented to me in my nail clinic with changes affecting his big toes for the last 8 years. He was a professional football player, but he had stopped playing football for the last 4 years. Importantly, there was no history of any pain in his toenails. So this is the patient on clinical examination. This is him up close. So I'll ask my panelists now that based on the examination, what is their clinical diagnosis? Dr. Faisal.
Yeah, if we start to see this patient, so as you can see, he has a thick nail on both sides. This one removed already, and we can see the loss of distal part of the nail bed. So that means this is chronic for a long time. For how long he has this problem?
8 years.
8 years. So this is chronic. So if we need to treat this condition, we have to inform the patient. We want just to make it better. We cannot reach the best solution for this.
So based on examination, what is the diagnosis?
Yeah, diagnosis here, it looks like onychogryphosis, plus minus acquired malalignment, and possible with the discoloration of the nail. Maybe we can see also onychomycosis there. So onychomycosis could be a super infection, comes after the disease. So what I suggest as treatment?
We will come to that.
Yeah, okay.
For the treatment. Yes, Dr. Michela, what is your opinion?
Yes, first of all, we have to describe the nail sign.
Yes.
You can see, first of all, this is a very thickness nail plate. It is typical when there is an activation of the matrix that start to produce a nail with an error, like this is a memorized, is a permanent dystrophy, and especially due to trauma. This is the activity of the patient. So it's possible that is started to grow a new nail that is started to be higher in the thickness and not so longer. It's possible that he never cut this nail, not only for the dimension, but also because they not cut, also because the cuticle is not well present, so important. It's a very thickness, so onychogryphosis, the evolution of the pachyonychia, maybe it is for the beginning, is typical of the 2 big toenails. And especially if the nail plate is so big, so thick, it's impossible to look at the nail bed and any colonization.
Yes. So this was a case of onychogryphosis. And what is this disorder? Onychogryphosis is a disorder of the nail plate growth, which is clinically characterized by an opaque yellow-brown thickening of the nail plate with gross elongation and increased curvature. It is usually described as a ram's horn nail or an oyster-like appearance. It affects the great toes most commonly, but can affect any of the nails, by the way. And the nail plate initially grows upwards, and thereafter it deviates to the side of the other toes. What is the pathogenesis? The exact pathogenesis is not known, but what is known is that one part of the nail matrix is producing the nail plate at a much faster rate, and this determines the direction of the deformity. What are the causes? In this patient, most likely the cause was trauma, but sometimes we can have infections like onychomycosis, which can also cause, although these may be secondary. Poor self-care is a very common cause of onychogryphosis as well. So now coming to the management, Dr. Michela, what are the management recommendations, and
Oh,
Would
first
you
of
do
all,
any investigations?
yes, first of all, we have to exclude any colonization by fungus, not because it's frequent in this type of nail plate, but because it's impossible to look at it with the typical sign on clinical onychoscopy. So it's important in any cases you have this thick nail, because if you have it, you have to treat before it on the basis of the different approach that you can have only in onychogryphosis. So it's important to exclude, first of all, the combination of onychomycosis, also because there is some yellow aspect, especially in the right toenail, can be similar to onychomycosis.
Okay, so apart from that, any other investigations? Would you perform an X-ray, Dr. Faisal?
X-ray, I don't think it's necessary here because we don't have element of exostosis or something coming from the bone. So what's important, I agree with Dr. Mikela, we need to do clipping.
Yes.
We need to do QH, so we have to rule out onychomycosis as a colonization with disease.
Okay.
Maybe X-ray can be recommended if there is pain, but you report at the beginning
There was
is
no pain.
pain.
Yes, exactly.
So in this case, the bone is never involved, because if you have it, you have pain, absolutely. Even if you want to exclude exostosis and so on, because it's impossible to look at it. So I think your information at the beginning exclude, I think, to ask an X-ray.
And it is bilateral, so we cannot do X-ray for both sides.
Yes,
Exactly.
both.
If something
It is
happened, will be
bilateral.
just one side. So this is bilateral. So
Yes. So in this patient, I had sent a nail clipping for a PAS staining as well as a fungal culture, and it was positive. The organism was Trichophyton rubrum. So now, based on this investigation finding, how would you treat this patient with the secondary onychomycosis?
So first of all, we have to treat the onychomycosis. It's very important because you have a positive culture. So
And how would you do that? Would you just give him orally, or would you avulse the nail?
The presence of Trichophyton rubrum indicate absolutely the use of terbinafine. It is absolutely advised to use oral terbinafine, local treatment.
But would you
It's
avulse
not,
the nail and then give the terbinafine, or would you
Together.
Together.
Yeah, it is better. Then we have, it's a one pill to 250 milligram per day for 3 months. It's well described in all of the publication. Then we have to treat locally the nail, because there is, yes, an onychomycosis, but you have to try to treat the onychogryphosis.
Yes.
And we have to reduce the nail plate, absolutely. It's very, very important.
Thank you. So these are the treatment options. So now in this patient, which of these treatment options would you use? Would you do a surgical option, or would you go for something else like a chemical debridement or a chemical cautery as the first line treatment?
Yeah, if you can go back again, so go back to the photo. There is many things we can discuss as a treatment. So
Yes.
Many options, many therapeutic options, but as I said from the beginning, we have to tell the patient we will make it better, but we cannot guarantee to make it 100% like before.
Normal, yes.
Because this is already chronic, this is 8 years. Already the nail bed is not anymore here in this side, so this is really a late presentation. So what I suggest, as we said in the beginning, we have to treat the onychomycosis first, then later, maybe this side here, because if you can see here, we can see the curvature, abnormal curvature of the nail plates going down through the nail fold. So it looks like a pincer nail. So like the procedure for pincer nail, we can suggest, for example, doing like lateral matrixectomy to make it a little bit better. But we cannot, as I said before, guarantee the result. And we can clean this thickened nail. So he needs many procedures to be done, and we have to follow the patient, and we see if it is enough, or we can do something more later.
Yes, Dr. Mikela?
Absolutely agree. We have to reduce in any cases. I prefer to start with a conservative way. I think the debridement is very important with the chemical, with the urea, high concentration. With maybe, in Italy, we have a very important role of the pediatrics, so they stay with us in the consultation, so they are very important for us.
Yes.
And it's a very good effect of mechanical trauma. My suggestion is not to arrive on the matrix, because the problem is that the matrix is already affected by the disease. So if you have to treat it, if you arrive with the surgery on the matrix, the problem is that you can worsening the situation. It's like a scar, you know, if you remove it, it's possible to have a very not nice scar as a hypertrophic scar. So I think you have to explain the patient that is a conservative way, that you have to continue by the time, because it's important to change the memory of this nail matrix.
Thank you. So there has been a recent case report about the use of intramatricial dexpanthenol injection for the treatment of onychogryphosis. And this was a very interesting case report from a group from Turkey. So this was a 22-year-old female with a history of these nails for the last 4 years, and she had undergone 4 total nail avulsions, but always with recurrences. So the authors, what they did is they gave her intramatricial dexpanthenol injection after a complete nail avulsion. They gave 0.3 ml of dexpanthenol injections perpendicularly at 5 to 8 millimeters, proximal and lateral to the junction of the proximal and the lateral nail folds towards the matrix. These injections were given at weeks 0, 2, 4, 8, 12, and 24 after the nail plate avulsion. And the results were amazing. They have a 5-month follow-up, and you can see that this is the result. There is an almost normal nail on the right side. So do you have any comments about this, Dr. Michela?
It is wonderful. I never performed it. I know Fatih very well. It's my friend from Turkey. I didn't use it in Italy. It's not easy to perform this without ethical committee and so on. But I think it is a very important role, because it's not easy to manage this type of patient with onychogryphosis, malalignment, and so on.
Yes.
So I think it can be a very good option. We have to take it in consideration.
Yes. Yes, Dr.
Yeah,
Faisal.
it's an excellent result. I agree with it. So why not to use it?
Yes. So now we go to our second case. This is a 55-year-old lady who came to my nail clinic with complaints of nail changes affecting her toes for the last few years. There wasn't any other significant medical history. This is her on examination. So what are your findings and what is your diagnosis? Dr. Faisal.
What we can see here, we can see distal onycholysis, distolateral or in the center as well. And we can see multiple Bose line, if you see both sides, the big toes. So 1, 2, 3, multiple Bose line. And we can see also that the direction of the big toe toward the second toe. So there is also
hallux valgus.
Yeah, hallux valgus is there. So this is most likely frictional.
Yes. Yes, Dr. Michela.
Yes, it is not only bone line, but it is a leukonychia, transversal leukonychia. So it means that transversal leukonychia of all the nail plate are induced by trauma in these cases. They also are parallel to the lunula, that is very typical of internal action on the matrix.
On the matrix.
When you have the bone line, it indicates that the matrix is affected by the superficial layer, so on the proximal part of the matrix. When you have the leukonychia, the trauma is deeper, that you have the ventral zone that reflect inside the nail plate. So we have all the inflammation, so the trauma can be very important. It is diffusely because most of the nail are affected.
Yes, so in this patient, she had frictional nail changes, and these changes, they affect the toenails very commonly. They are as a result of inappropriate footwear, in addition to the bony deformities. For example, she had the hallux valgus, which is very common. So which are the frictional and the compressional nail changes? They include ingrowing toenails, Bose lines, traumatic onycholysis, melanonychia, striations, hematomas, as well as pyogenic granulomas. And these are examples of some of the changes due to footwear along with the toe abnormalities. The two most common toe abnormalities are the hallux valgus and the hallux erectus. So what would be your treatment approach, Dr. Faisal?
So the best thing we have to address the patient to a podiatrist to help her to maybe to put like a spacer between the toes. So this is the best solution. And we can ask the patient to wear open shoes,
Yes.
wide shoes, so to avoid any traumatic could happen to the nails. And we have to reassure her because most of them, they are coming. If they see this is discoloration, they are coming, they are thinking there is like onychomycosis. So this is because of the...
Should we perform any investigations in this case, or?
For me, no.
No, I think it is a very bilateral, so
Yes.
it's very difficult to do also because of the clinical, but also the onychoscopy aspect is very linear, border is a very homogeneous color, so I think it is only traumatic.
Yes.
I think that also the trauma reflect maybe the thickness of the nail plate. It's not, they are not so long, so it is not because they are not a good cosmetic, but so for this reason it's better also to suggest a locally therapy with urea, with like 40-50% every day, because the urea induces the softness of the nail plate, and in the shoes it is possible to reflect less the effect of the trauma. It's very
Yes.
good in these cases.
Yes, thank you. Yes, so these patients, they require that we have to refer them to the podiatrist. And in all these cases of hallux valgus and hallux rigidus, this is a must. We should also advise them about proper shoes, which should fit the feet and not the feet to fit the shoes. We can also advise them toe exercises as well as silicone prosthesis. So these are some of the toe exercises, which include the toe raise, toe curl, toe squeezes, as well as toe pulls. Now coming to our third case, this is a 17-year-old girl who presented to me with nail abnormalities of all her 20 nails for the last 7 years. She had received multiple treatments in the form of Divobet gel, phototherapy, as well as intra-nail injections of methotrexate without any benefit. So these were her nails. She was very distressed and her mother was crying, but now they had given up all hope. These are her toenails, and this is her onychoscopy. So what is your diagnosis and why? Is this a case of tracheonychia or is this something else?
Yeah, for me, this is a case of tracheonychia, so we can see total nail dystrophy, so affecting the whole nails, hands and feet. So tracheonychia is a medical term, so we have to look what's the possible cause of the tracheonychia. So it could be due to lichen planus, but for the disease duration, 7 years, so and there is no any
Scarring.
signs of lichen planus, so we rule out lichen planus. So idiopathic, not idiopathic, because now 7 years and there is no improvement, and the age 17 years old, so usually idiopathic with the kids more. I think it's more with psoriasis. And if you can see there is thickness also. You can see there is also subangular hyperkeratosis.
Yes.
So in absence of skin disease, so for this I think better to do a biopsy to confirm it. The age 17, as I think it's easy to do biopsy for them, to convince them, then to start the treatment after, according to the results.
Yes, Dr. Mikela.
Yes.
Do we see such thick nails in tracheonychia?
Tracheonychia is a superficial alteration due to the inflammation of the matrix. This is important. It's a benign condition in 80% of the patients, especially in children. But sometimes can be a spy of psoriasis, alopecia areata, lichen planus, atopic dermatitis, and so on. We have to describe the sign. This is a superficial layer, and it is typical of pithing, and the pithing is irregular. So we have completely discarded the alopecia areata because it's completely irregular. On the other side, we have no fragmentation of the distal part, so no longitudinal fissuring. So we have to exclude the lichen planus, nail lichen planus. And finally, we have the hyperkeratosis. Subungular hyperkeratosis is completely white, it's not yellow, so it's impossible to be onychomycosis. And for this reason, after this, we can conclude absolutely that it is a nail psoriasis. Hyperkeratosis, subungular hyperkeratosis with a whitish aspect is only of nail psoriasis, typical of the nail, toenails that before we saw in the picture of the toe.
Okay.
Yeah.
So in this patient, I performed a nail biopsy. and the result was psoriasis. So now, like, how would you approach the treatment?
So
Dr.
this is
Faisal.
here we have both, as we explained previous lecture, that we have nail bed involvement and we have
Nail
nail
matrix.
matrix involvement.
Of
And we
all the
have,
nails.
we have more than 3 lesions, so more than 3 lesions and lesions with just nail dystrophy. And sometimes they are coming with the pain. Sometimes they are coming with the, they hide their nails in front of the others, in front of the school.
That was happening to her,
Yeah,
yes.
so they want active treatment. So it's impossible for her to do injection because sometimes they are doing injection, but I don't believe it for the 20 nails.
20 nails.
So it's difficult, it's painful, so it's not a good choice. For topical treatment, the nail is thick like this. So
very thick.
where we apply it? So we cannot do it. If it is just nail bed by nail bed involvement, we can do a cream, but here we cannot for the topical treatment. What we suggest, we go to the systemic treatment. Systemic treatment, there is many options. So we have to discuss it with the family, and we have to choose according to the patient profile and history. If there is a history of IBD, so we can choose what is available also in our clinic.
Yes, Dr. Mikila.
Yes, we have to follow the guideline. We have to start with the local therapy that you already done
Yes.
before to ask the blood examination, maybe to start a systemic treatment because all the nails are affected, so it's
Yes.
impossible to start with a locally intralesional or locally cream, gel, and so on because it's too many nails
Yes,
that are
exactly.
affected by. Then we start methotrexate that I saw before with not a good result. In Italy, but not all countries have the different guideline, absolutely, especially with the general system. We need to have the failure of 2 systemic drugs before to go to biological therapy. So in this case, it's more metric, so maybe you can decide to do acitretin, but don't forget it's a
In this
17
age,
years
yes.
old,
Yes.
so it is not easy to prescribe it for the pregnancy test and so on. Maybe in these cases, because cyclosporin it's not affected when there is so involvement of the matrix different from the bed. Maybe you can start direct as a methotrexate, it is the best, directed to biological.
Yes. So that's what I did. After I received the biopsy report, I started her on ixekizumab, and this is her just after the loading dose. So I'll be following up with her later on. Now we come to our 4th case. This is a 23-year-old lady who presented to me with a painful left big toe of 2 years duration. She had undergone several partial nail avulsions under GA by the orthopedics, which was like really insane. So what is your diagnosis and why? Dr. Mikela, now?
So in this case, we have a completely onychomadasis and dystrophy of the proximal part. There is a very important alteration. You can see that this separation, that is onychomadasis in painful nail, is a very sign in young patients for a lot of years of retronychia. It's a very important, this is again a trauma disorder where there is an interruption of the matrix due to a trauma that started to again regrow a new nail that take with them the previous one. You can see, in fact, 2 nails
Yes,
in
there are 2
the,
nails.
but we don't know how many nails are back. So in these cases, we have to discover it.
Yes, Dr. Faisal, any comments?
Yeah, I agree. There is onychomatosis, as you see here. There is multiple nail, one nail here, one nail here, and there is also inflammation at the proximal nail folds. So this is a typical case, but it's late presentation
Yeah.
of retronychia. So it is not onychomycosis. This is a typical case of retronychia.
Retronychia. Yes. So that was my diagnosis. So this is a condition which is an inflammatory disorder typical of the great toes, characterized by an arrested nail growth, ingrowing of the nail plate into the proximal nail fold and paronychia. It affects the females more commonly, and the pathogenesis is that the lateral horns of the nail matrix adhere strictly to the nail plate, thus avoiding its detachment. There is a new nail which grows underneath the old nail, and due to the continuous trauma, there is continuous inflammation of the proximal nail fold. So what would be the approach to the management of this patient? Is there any classification of retornicea which has been described recently, Dr. Michela?
In this case, the investigation are not useful. So even if there is a yellow color of the nail plate, it's not important to exclude or not onychomycosis because you have to treat it with different degrees. In the paper, we describe 3 different degrees. We have a severe in these cases,
Yes.
not mild, not moderate, that you can use a local therapy as a high potency steroid under occlusion or intralesional steroid. In this case, it's a very severe. I think it is better to do the avulsion of the nail plate because it's impossible to have a resolution without surgery. You have to be weight, especially with the anterior part, because the problem when you do the anterior, the nail avulsion, it is possible to have in 30% of the cases the dystrophy, like ingrown anterior layer, like this ingrown nail of the anterior part, because it's very typical of the hyponychia to grow up. This is the real problem. But in this case, it's impossible to have, I think, another option.
Okay. So when would you perform an intralesional steroid injections in these cases?
In these cases, the paronychia is not so like this. You can see in stage, the first one or the second one, you have the redness aspect of the paronychia. In this case, and the nail plates are completely not up to the nail fold. So it's possible to stop it, not to go versus the nail avulsion, as in the case of you. And it is a very good option because you never do nail avulsion, not avoid the possibility of the dystrophy.
Yes.
But if you have the completed detachment of the proximal part to the nail fold in the proximal layer, I think it is very difficult to not do nail avulsion.
And how would you do the intralesional injection?
Intralesional injection is dilution 1 to 3. And you have to put with an insulin typical, you have to put in the lateral part of the proximal nail fold. It's important to inject here, 1 here, and 1 here. And you have to put 1 every 1 month and a half, 45 days. And it's possible to have also 3 sessions to be sure there is the new nail that start to grow completely together with the previous one, so you don't have more the steps from one to the others. Okay. It's a very good result with intralesional steroid.
So these are the 2 papers that Dr. Michela has published with her group, and you can go through them. And these are the treatment options that she has just discussed with us. In which cases would you use topical steroids, Dr. Faisal?
For our case, no, because it's just it's very late.
It's the late stage,
It's a late stage, and there is inflammation already of the proximal nail fold, and the nail is very thick, and I think it's painful also.
Yes.
So we cannot apply cream, so we need to do surgery. So for this case, and injection also, it's too late for injection now.
Okay. In which cases would you use a topical steroid amongst the 3?
As you mentioned earlier, so we can use it for the mild diseases like this, like the second one, the first and the second one. So we can use it especially here, and even here we can use the topical cream, and we give them time. So we ask them to come after 3 weeks or 4 weeks. If there is improvement, okay, we can continue with the same. If there is no improvement after, for example, 2 months, 3 months, there is no improvement at all, there's still pain, then we go for the surgery.
Okay. So I thank you all for your kind attention, and I thank the panelists, and save the date for the 5th RADV next year. Thank you very much.
Thank you.
Thank you.
Good afternoon, everybody. First, I would like to thank our panelists for being here. We have Dr. Adlal. She is the head of Asad Al-Ahmed Dermatology Department in Kuwait. We have Dr. Jawahar Naqbi. She is a consultant dermatologist currently working in Dermamed Clinic in Dubai. We have Dr. Ashraf Rida. He is a head of consultant dermatologist at Medcare Willcare Hospital. And we have Dr. Sri Kumar. He is head of dermatology at Dr. Joseph Polyclinic in Dubai. So we have 3 cases. We will start first with case 1, which will be for Dr. Ashraf and Dr. Jawahar. So we have a 15-year-old female. She is known case of atopic dermatitis in childhood, which resolved. She presented with history of very itchy lesions all over the body in the last 4 months. So she had the rash, itchy rash since 4 months. She has positive family history of eczema, and her total IgE was elevated above 100. And there was no skin biopsy done before for her. Initially, she was diagnosed as atopic dermatitis. She was started on Rinvoq 15 mg OD. After 3 months, she didn't show any improvement and her rash worsened, and she was advised to increase the dose to 30 mg. So this is the clinical features of our patient. So as we can see, she has mostly excoriated papules on upper and lower limbs, with some eczematous-like lesions on the dorsum of the hand. So any thoughts for the diagnosis, Dr. Jawahar?
Thank you so much, Dr. Amal. Actually, it's a very interesting case. This is very familiar with most dermatologists, and one of the cases and the scenario we may see in our clinic. So here the case is, the patient is 15 years old, known to have atopic dermatitis on a systemic approved medication, which is Rinvoq. So the issue is failure of treatment. So I think most of the dermatologists, I cannot say most of the dermatologists, but we can say that maybe the issue here will think about why the treatment, which is Rinvoq, failed, or even other medication. So shall we shift the patient from Rinvoq to another, for example, JAK inhibitor or biologic, the other approved medications, or we have to think more about the patient and its presentation? So what we understood now that the patient is known to have atopic dermatitis since childhood, and what's mentioned in the history resolved, but in the last 4 months it recurred as eczematous patches plus itching that presented, but no improvement with one of the approved medication. So I think, Dr. Ashraf, here we need to know more about the history, to take proper history, and to do complete clinical examination to, of course, to confirm the diagnosis before we shift to another medication. So,
yeah, actually, the case history, whatever we got, and the clinical presentation fits well with atopic dermatitis. Family history of atopic dermatitis, early age of onset, although it was resolved and came back. The lesions on the legs might look like prurigo nodularis as well, which in 50% of the cases can be associated with atopic dermatitis. The hand lesions could be contact dermatitis with atopic dermatitis. So I don't think that, I think most of the dermatologists will consider it atopic dermatitis and will start. But after 3 months of Rinvoq without any improvement, even worsening of the case, one should revise the diagnosis. The typical criteria of atopic dermatitis can be mimicked by other conditions sometimes, like mycosis fungoides in adults, like fungal infections, like contact dermatitis, like scabies. All these should come into the differential diagnosis, especially after failure of the treatment. I don't think that we should raise the dose to 30 if there is worsening of the condition, because we can raise the dose if there are at least 30% improvement, but zero improvement or even worsening. So I agree with Dr. Jawahar that we need to revise the diagnosis in cases of atopic dermatitis if not responding to the treatment.
So
exactly, and what has happened
sorry.
also with the itching, the nature of the itching, it's especially with Rinvoq, we are talking about JAK inhibitors, one of the excellent medication that improve absolutely good percentage of the severity of itching. And here, the itching itself was worsening under the treatment. So proper history, like if other relatives, any family members complaining or suffering from the same problem may think about, for example, scabies. As the presentation, as we see here, some scratch marks, some excoriated lesions, worsening of itching under the treatment. So scabies should be excluded, for example, in this case.
Any treatment you suggest for this patient other than Rinvoq?
Sorry?
Any treatment you suggest to start for this patient?
So first here, as we mentioned, we should take a proper history and we do complete clinical examination, and according to the finding that we see, we should exclude scabies. It could be atopic dermatitis plus another skin conditions that mimic in its skin lesions. So it could be scabies, and we should treat it with scabies treatment.
So
Before we think to shift from one systemic to another systemic treatment.
So for this case, scabies was highly suggestive. Patient was started on ivermectin and permethrin, and this is the patient 2 weeks after treatment.
Excellent.
So what are the learning objectives of this case? We want to emphasize about the importance of taking detailed history, including the family history. Also the importance of a good physical examination to not miss clues for the diagnosis. Also the importance of making the right diagnosis before starting a systemic therapy, like here, Rinvoq. Moving to the next case for Dr. Shri Kumar and Dr. Atlal. So we have a 38-year-old healthy male. He presented with a rash that started on the scalp, then spread to the limbs for 2 months duration. So he had a rash or skin lesion since 2 months. A rash was asymptomatic. He was initially diagnosed as psoriasis. He came to start his biological therapy, secukinumab, as advised from another clinic. He didn't start there due to insurance problem. He had no significant any past medical or drug history, and no investigations, including skin biopsy, was done. So here are the clinical picture. As we can see on the scalp, we can see a few erythematous plaques. And here we can see brown papules and plaques with colorate of scales involving the palms and soles. So Dr. Shri Kumar, any thoughts?
Very interesting case. Actually, I would start by saying that the eyes do not see what the mind does not know. This is a common proverb for all of us in the medical field. So actually, when you look at this case, it has got a very characteristic picture, especially the palms. A split papule with erythema and bilateral symmetricality is a hallmark. So yes, you can have lesions which look like psoriasis in the scalp, and the most important thing probably is the total duration of the skin lesion. So I would rather hesitate to start that to a biologic agent in a case like this, assuming that it is psoriasis. Because diagnosis of psoriasis is something, yes, the gold standard is a clinical diagnosis, but you should have some nail changes, you should have some classical lesions, and if not, at least a biopsy should have been performed. So biopsy has not been performed, and assuming that this is psoriasis, secukinumab is being considered. So I would say that what is most important is a thorough clinical history, especially the duration, onset, progress of the clinical lesions, and keep in mind the differential diagnosis of psoriasis-like lesions, and take into consideration the classical distribution of the lesions and the classical appearance of the lesion, and create a differential diagnosis, and thoroughly examine the patient and do an appropriate test before we decide on the treatment.
Yeah, adding to Dr. Kumar comments, any involvement of palms and soles in a young age group patient, I would elaborate more on history. So we'll ask him about medication history, any previous medication taken. And we'll ask him about his sexual activity and if he's sexually active. Because two things came into my mind whenever I have these kind of localized palm and soles. First on the list will not be psoriasis. I will think of EM-like lesions, drug-induced EM, or I would think of ruling syphilis, which also can present with secondary psoriasiform lesions. So these, I think, elaborating more on history taking of that patient will help aid in the diagnosis before jumping into biological treatment. So digging more in the history would be so beneficial for that patient, and subsequently asking for the beneficial investigations.
Okay, for this case, a syphilis was highly suggestive, and both his specific and non-specific test came positive, and a final diagnosis of secondary syphilis was made. So what are the lessons from this case is about the importance of, again, good history taking and physical examination, and to do blood test or skin biopsy for any suspicious rash, and the importance of making the right diagnosis before starting systemic therapy. Moving to the last case, which will be for the audience. We have a 25-year-old previously healthy male. He presented initially to maxillofacial surgery for a 20 days history of a sudden onset of swelling on the face associated with skin lesions. He had no systemic involvement, including fever, lymphadenopathy, or splenomegaly. So again, 20 days, he has skin rash. The rash was painful. Incision and drainage was done for this patient, but the lesion soon progressed to involve the whole lower face, and he had no risk factors of immune suppression or contact allergen to the face. So this is the clinical picture of our patient. As we can see that lesions involving mostly the lower part of the face. We can see cystic nodules and plaques with some yellow to brown crustation. This is the right side of the face, and we can see the scar of the previous incision and drainage. And this is the left side of the face. So any thoughts of what could be a diagnosis? Rosacea? Sorry? Tinea barbi. Any other? Fungal? Other differentials? Yes? Eczema herpeticum. Okay, when he was under maxillofacial, they thought that it could be abscess or any bacterial infection. He was started initially on multiple antibiotics, including IV tazocine and levofloxacin, with only minimal improvement. They did a wound culture, 3 wound cultures, all came negative for this patient. They suspected that it could be infected herpes zoster or herpes simplex virus infection. Both came also negative for this patient. They thought that the patient is immune suppressed and he could have an HIV. Also HIV and TB came negative for this patient. Finally, he was referred to dermatology, and our first impression that it could be pyoderma faciale. Other differential, it could be psychosis barbae, tinea barbae, acne fulminans, or simply contact dermatitis. Patient was, we took skin biopsy for this patient, and he was started empirically on doxycycline. He took 100 mg/d for day 1. After that, it was shifted to OD. This is the patient only 7 days after treatment. We can see the significant improvement in his lesions. Skin biopsy came out, and as we can see, there's diffuse dermal infiltrate, and the infiltrate also involving periadnexal and perivascular. The inflammation was primarily consist of neutrophils, as we can see here, surrounding the sebaceous gland, and a final diagnosis of rosacea fulminans was made. And the message from this case that early suspicion is a key for a proper and early treatment to avoid any surgical procedure like our case was done on the face. And thank you.
Thank you. Just to add a comment on the last case, any young patient coming with acute onset of facial lesions like this patient, painful, oozing pus, we want to rule out infection, definitely. This is one whether it is bacterial or fungal infection, as my colleagues mentioned. And the other thing is we wanted to know the history of rosacea or acne. So we'll think of acne fulminans or rosacea fulminans. So yes, these two are the top priority. And the one you've mentioned that you did the HIV, so we'll think also of presentation in immunocompromised patients, so we'll do HIV, which I think it was really a good decision to do.